All right, so sir, can you tell me what is going on here? What are your symptoms? What happened to you? So he's not talking much. Enough said. All right. So he's already smiling. Give me a big smile here. Okay, so we know he's faking it. All right, can you close your eyes really tight and open your eyes? Now, can you open your hands? Close your hands, is following commands. Can you tell me, what year is it today?
Do you want me to talk or no?
Yeah, you
Okay.
can talk.
2016.
And what month is it?
November.
And how old are you?
34.
Okay, you don't have to ask the year, but I always ask here to make sure that they're oriented. All right, very well. Now, let me ask you to do a couple of things for me here. Give me a big smile. Very good. So this smile is symmetric.
Anything in my teeth?
Yeah, it looks great. Yeah, it looks great. Now, I want you to follow my finger. So far, everything is very easy. You're just asking level of consciousness. You want to know, if they're alert, oriented, attentive, and everything so far is easy. Can you follow my finger here, just with your eyes?
Oh.
So here is where we instruct him to have, just follow with the eyes. Just follow with the eyes. Don't move your head. Don't move your head. And what I'm going to do is this. Follow my finger. Follow my finger. Follow my finger. You're getting sleepy.
Watch my wallet, Betsy.
I'm doing a magic show here. All right. So now, if I had my finger more close, I'm going to converge his eyes, and it's not comfortable. So you don't want to be too close. You want to be just enough of a foot or so away. And what you want to do is, if you just make an H, that will examine all the extraocular muscles. So that's really a good way to do it. If you do it too fast, then they'll get dizzy. It's not comfortable either. All right, now I want you to look at me. So here is the thing. Now you have to imagine that he's lying down. And by the way, the best place for the robot to be is right at the very end of the stretcher. And for the head to be up adequately enough so that we can see what we're seeing. But now, if the robot is here, I'm going to ask him to look at me, not at the robot. Look at me, and look at my nose here. How many fingers do you see?
One.
How many fingers do you see?
One.
How many fingers do you see?
Two.
How many fingers do you see?
One.
Okay.
Did I pass?
Not really, but we'll talk about it later. Now, how many fingers do I see? No, look at me here.
Two.
How many fingers do you see?
Two.
You sure? So the point is, if you have two fingers, don't do this. Do this. And how about now?
Two.
How about now?
Can't say anything.
Right. So unless he's an amphibian with eyes around him, he won't be able to see that. So you have to be aware of the physiologic blind spot. So if I'm too close to him, he won't see it. You got to take a distance between you and the patient and just kind of cut it in half. And you want to be right here. If they have a hymenopsia, they won't see that side. I promise you. Sometimes if we want to get a detailed exam and have the patient cover one eye or the other, in our experience, it complicates things and it makes things very, very messy and it never really gets done very well. So when we're doing a quick screen, we would rather just do that. And now try to just do 1 or 2 fingers, so don't do 3 or 4 or 2.5 and 5.5. It's 1 or 2 fingers that are there. All right, and once again, have them look at you, not at the screen, because then that's going to change the scope of the visual field. All right, any questions about the visual field? All right.
How far, when I'm doing it, I try to stay like this, not go, hands up. Obviously not going too far back. That's an area I'm just a little uncomfortable with when I'm doing the fields.
Right, exactly. So what you would do is, again, just between you and the patient, right in the middle. You don't want to be too far or too close in that. And don't do the bird. When people do the bird, don't do that. 1 or 2 fingers will do. All right. Now let me have you bring up your arms here. Turn them over and close your eyes. And keep your eyes closed. So we're checking for drift. He's trying to fake it. He doesn't know how to fake it yet. So we're checking for drift, waiting for 10 seconds. 10 seconds is not 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 seconds is 1, 1,000, 2, 2,000. So we're waiting for 10 seconds up here. And the other thing that we sometimes may ask you to do is to check for extensor drift. So when people have a little bit of weakness and there is some pyramidal weakness and there may not be a very obvious drift, sometimes I ask them to do this and bend your fingers back. And sometimes when you don't really appreciate a full drift, sometimes you can see a little bit of extensor drift. That's always real. That's a pyramidal weakness because the extensors, deltoids, triceps, and extensors are the muscle groups that get weak when there is a stroke. You can push your arms out, sorry. It's getting tired there. So, so you have to imagine that that distribution. You know, it's the extensors of the digits, the wrist, and triceps and deltoid are the ones that get weak when people have a stroke. Now, you saw the slide that was shown earlier with the homunculus that Dr. Abouawad was showing. If you remember the homunculus, you have a large face and a large hand and a very small arm. That means that the distribution of the brain, the parts of the brain that correspond to face and the hand are larger than the arm, than the rest of the arm. Why is that? Because there's a larger number of nerves, right? So when you look at the motor cortex in the frontal lobe, there's a lot of little muscles that do a lot of fine things here, right? There's a lot of little muscles. All those muscles have to be supplied by nerves. And all those nerves end up occupying a larger part of the brain. So patients come in with hand weakness or distal upper extremity weakness, not so much arm weakness. You never see a patient completely normal hand function and extensor function, but deltoid weakness with stroke. You never see that because just not physiologic. So there's a larger probability of getting facial weakness or hand weakness with an MCA stroke, because remember the homunculus is large face, large hand. And the same thing on the sensory cortex. So there's a larger probability of getting numbness in your hand as a sign of stroke than shoulder numbness. You never see a patient with shoulder numbness, right? So for that reason, when you want to test this and you're checking for drift, and they may not have much of a drift, if you check more for extensor drift, you're going to see it if they really have something. The same thing with the sensory. When you're checking the sensory, it probably pays more to check the sensory distally in your hands and the feet as compared with proximally, because that's where it preferentially will get affected. So let's move forward with this. So now we're going to check the coordination. Let me have you make a pointer finger here. Touch your nose and touch my finger. Touch your nose and touch my finger. Now a lot of people do this. Go ahead. Okay, and touch your nose again, and touch my finger. Don't do that. You don't need to do that. It confuses the patients. But what you can do is go ahead and touch your nose and touch my finger. You see how easy it is? What you can do is to stretch your arm a little bit. So when they stretch, that bit of a dysmetria will get amplified as they stretch their arms. So that would be important. All right, and in the lower extremity, it's kind of difficult to demonstrate here because he's seated, but let's go ahead and raise your right leg here. No, just raise your right leg here. And so we wait for 5 seconds here, and then we bring him down, raise your left leg. Perfect. And now let's do the heel to shin, pretend like you're supine. So we take the heel, go up and down the shin bone, and you're looking at the path of that to make sure if the path is erratic, then you're looking at dysmetria. Very good, and that's that. Now remember that for the sensory exam, remember that the highest yield are the face, hand, and feet. So one thing that we find, oh, you have that? Oh boy, she's right on it.
Can you give me a prick?
Now he's sweating. So one thing that's available in all your rooms are these little wooden Q-tips.
I just undo this.
Boy, you're not kidding.
What name is that? Where's that going?
Just relax. You don't want to move. It will hurt more if you move. But so what you want to do is to take the Q-tip and break it into half, or a tongue depressor, and that will create a sharp edge. Sometimes, or a blunted needle is sometimes also good, but what's available everywhere are those things. And you really want to use a sharp edge for this. You don't want to use just soft touch as your only way to examine this, especially when you were thinking that it's a sensory loss there. So what you want to do is just you want to prick, 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 prick. You don't want to just do a little scratch. And some people do like a little acupuncture thing. Do you feel that? No, you don't want to do that. So you want to just do prick, prick. Just imagine this is a blunted needle here. Prick, 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 5 pricks here, 5 pricks here. Do you feel that the same way on both sides?
Yes.
So what I'm looking for is symmetry. And the same thing with the hands. You feel the same way on both sides?
Yes.
And the same way with the feet. Now, we do it on bare skin. We don't want to do it on clothes, obviously.
I'm taking my shoes off.
That's all right, don't worry about it. You understand? With the prick, just remember, you got to have a good prick motion. You don't want to go like this or scratch, and that, you know, if you're too gentle, they won't feel the prick there. So that's the sensory. Now, language. Do you have those cards for the anti-stroke scale? Yeah, the language part is pretty simple. We're checking for naming. We're checking for fluency and repetition, right? So remember the fluency, the motor part of language, how fluent, how articulate the person is. It's in the frontal lobe, right under the motor cortex. So that's the fluency. So if somebody has, it's called Broca's area, right? If somebody has a stroke in the frontal lobe affecting that Broca's area, they won't be fluent. But they'll be able to understand, but won't be very fluent. So smaller MCH strokes will just predominantly affect the Broca's area. Comprehension tends to be relatively intact, but their fluency gets affected. So they're very frustrated because they understand, but they can't get the words out. That's a Broca's aphasia. Whereas when the temporal lobe, the very back part of the temporal lobe called the angular gyrus, that's the Wernicke's area. When that gets affected, then people have a problem with understanding spoken language. So that's comprehension. So those are really the aspects of a language exam. It's naming, repetition, comprehension, and fluency. Okay? So it's difficult to from the earlier slides, you can just kind of go over that again to go over the language centers. But just know that the fluency, the motor part of language, is in the frontal lobe. The understanding part of language, understanding spoken language, is in the very back part of the superior temporal gyrus, back part of the temporal lobe. And so if I were to have you repeat after me, no ifs, ands, or buts about it. Okay, very good. So what happened was she heard the sound, she broke down those monotones and understood how they're connected together, and then she compared it with a memory bank of verbal cues that she's learned and then she understood it. So that's the understanding part. Then that connects to the frontal lobe. The frontal lobe then carries out the speech. So it's a circuitry. Right? So what happens is, if anywhere in the circuitry is affected, then people have aphasia. If the frontal lobe one gets affected, then people have an expressive aphasia because the fluency, motor part of language gets affected. If the temporal part gets affected, then they have a difficulty understanding. That's called Wernicke's aphasia. And so, and when everything is affected, it's called global aphasia. But it's a circuitry, so if anywhere in the circuitry is affected, naming is going to go. So if you are wondering if your patient is aphasic or not, test the naming. If you have 2 seconds to test the patient, test the naming. If you have an 80-year-old with a urinary tract infection and dementia, they'll tell you it's 1929, but if they're not too sleepy, they'll be able to name objects just fine. They don't have aphasia. Whereas on the other hand, the 56-year-old who is aphasic, will look like they're confused, but they're really aphasic. So you can't make that mistake. They look like they're confused. But if you test their language function, then you see they can't name or repeat. So naming and repetition will go with aphasia. And that's why the NIH stroke scale is really based on that. So we'll have you repeat after me. Mama.
Mama.
Tip top.
Tip top.
50-50.
50-50.
Huckleberry.
Huckleberry.
Thanks.
Thanks.
Baseball player.
Baseball player.
No ifs, ands, or buts about it.
No ifs, ands, or buts about it.
Methodist Episcopal.
Methodist Episcopal.
So that's the extra point. That's extra credit. So repetition is good, and now with the naming, you have the NIH stroke scale cards that go that you point at. So you have the feather, chair, etc., and they'll be able to name all those objects. The other part of that is reading the sentence, because that gives an idea about the fluency. And then the other part is actually looking at a picture and be able to describe the picture, and that's also will test the fluency. Now, the other little trick about the picture is, first, when you show the picture, do you know what picture I'm talking about, with the mom and the two kids? And so when you show the picture first, just ask them, how many people do you see in this picture? Because if they have a visual field deficit, they won't see one side or the other. And so sometimes that answer is very interesting. Then the other part to check here is neglect. What's neglect? So that's one reason why patients don't come to care, because they're not aware of their deficit. That's neglect. So now if we were to have a patient with a stroke in the right hemisphere, let me backtrack, a patient with a stroke in the left hemisphere, oftentimes it leads to aphasia. So in most individuals, 95% of individuals, language centers are in the left part of the brain, even in 2/3 of the left-handed folks. So left brain, for all practical purposes, is language, and right brain is neglect. So if we have a right brain stroke, we get neglect. So if we have a right hemispheric stroke, we get neglect of the other side. If I have a right PCA stroke, occipital stroke, I get a neglect on the visual part, so I may not be aware of my visual field deficit. So here, if we have a right hemispheric stroke, we'll have a neglect. Now, sometimes that's part of the program. Just a little. I don't know if I'm supposed to dance here or not.
You're testing the auditory? I don't know what that is.
That's from Phenomenal.
Might as well just dance.
Yeah. We just met.
Sorry.
All right, no problem. I was trying to get used to that one.
Play that in the ER. Every so often. No.
So, neglect. All right. So one last point on neglect. So when people have a parietal stroke, right, they have sensory loss. When they have a thalamic stroke, they have sensory loss. So now if we were to have a stroke here, we have a dense sensory loss here, then it may be difficult to test for neglect. So let me expand on that a little bit. So how do you test for neglect? You say, close your eyes. Which side am I touching?
Right.
Which side am I touching?
Left.
Which side am I touching?
Both.
Right. Now, if he has neglect of the left side, we would say, which side am I touching?
Say right.
Which side am I touching?
Left.
Which side am I touching? Say right.
Right.
Right. So if he has a neglect, he won't feel with simultaneous stimulation. He's not going to feel the other side. And that's because he's not aware of the deficit. Now, if he has a stroke that will cause dense sensory loss, we say, which side am I touching? Say right.
Right.
Which side am I touching? Say, I don't know.
I don't know.
He won't feel that. And now, which side am I touching?
Right.
Yeah. He says right, not because of neglect, but because he can't feel that side at all. If I can't feel this side, he say right, he say, I don't know. On both sides they say right. But that's not because I have neglect, it's because I can't even feel that side. So in those cases, we always test for vision. So now, can you look at me here for a second? Which side do you see my finger?
Left side.
Which side do you see my finger?
Right side.
Which side do you see my finger?
Do you want me to answer right side?
Yeah, both.
Right. Both. Okay.
But if you had neglect, it would be the right side. So if we can't test one modality, we'll test the other modality. And that's how you test for neglect. Does that make sense? Yeah, do you want me to explain?
You have to really pay attention to what you're asking.
Yeah. So here, you ask the patient, close your eyes. They close their eyes. I'm going to touch you on the right side, left side, or both. You let me know which side am I touching you on. Which side is that? Right. Which side is that? Left. Which side is that? Both. The whole point of that is to do it on both sides. So if they have neglect, they'll only say right, because they're not aware of that side. But the reason we go right and left to begin with, because if they have a large deficit and they can't feel that side at all, and you simultaneously stimulate them, they're going to say right, not because of neglect, but because they can't feel it. So in that case, it's a good idea to test for visual neglect. Does that make sense now? Any questions about that? That's the last part of it. Thank you very much.
Thank you, Doc.